Hello, welcome to the third and final Diabetes Technology Network webinar. I'm glad that you've been able to join us this evening. We've got over 260 people registered this evening, which I think reflects just how topical some of the issues are that we'll be discussing tonight. I'll hand over to the panel who will introduce themselves.
Hello, I'm Peter Hammond. I'm a consultant diabetologist from Harrogate in North Yorkshire and a member of the Diabetes Technology Network Committee.
Hello, my name is Ian Cranston. I'm a diabetes physician based on the south coast in Portsmouth. I also have a strong interest in diabetes technology, and I'm a recent member of the technology committee, but with a particular interest in hypoglycemia and hypoglycemia problems related to treatment of diabetes.
Thank you. So I'm sure that many of you will be aware of the previous webcasts that have gone out. If you haven't had the chance to watch those, they are available online. If you Google Libre ABCD, you'll have access to the full webcasts, and you can also access the individual modules. And so whether you're a healthcare professional or a person living with diabetes, hopefully you'll find these useful. So tonight we have three different topics that we'll be discussing. The first one is exercise with Parth Narandon and Rob Andrews, who unfortunately can't be here with us in Loughborough tonight, but they will both be dialing in and will be available to take your questions. We'll then have Ian presenting on glycemic variability, and again he'll be able to address any questions you may have relating to that. And although he's not here yet, hopefully Pratik Chowdhury will be joining us towards the end of the webinar and will be available to take questions on the trend arrows. So I think we'll start off this evening just discussing the updates with the Libre in the UK, or particularly in England. Since our last webinar, the NHS England criteria for going on to the Freestyle Libre has changed substantially. And I just wanted to open this up to the panel and get an understanding about how that's impacted on the number of patients you see being referred for Libre and the impact on your services. So any comments?
So I think the big change from our perspective has been the indication for people who might have a psychosocial reason for going on to Libre, and I think that has allowed us to provide Libre for people who otherwise wouldn't have fulfilled it for the number of times they were testing each day, or because they were thinking we might have been putting them onto a pump. So I think that's been really helpful. Interestingly, I think our local GPs have picked up on that fairly quickly as well, and are identifying people that they think might benefit. And I think part of the problem is that the previous guidance has all tended to be very much focused on where you might be saving cost, or where you wouldn't at least be getting extra cost from using it, and that hasn't always been in the interest of, I mean, it hasn't allowed us to use Libre for people who would benefit from it from a clinical perspective. So I think that's been a big change, and we've already seen some people coming back. I mean, early days, but after a couple of weeks, who've just found it makes so much difference, and the reduction in their diabetes distress and the burden of managing their diabetes, I think, has been huge. So I think that's probably the biggest change from our perspective.
And what about people going through on the occupation indication? Have you had many going through on that criteria?
Yeah, so I think for a while we'd felt that we should be able to use it for people. We have people who work in kitchens and things like that, where testing glucose levels is really difficult. I have some chap who works up on a electricity pylon who needs to test, plenty, and so it's those kind of things where I think it is really so yes, I think it's important that we are we're honest about using those indications, because I think if we just use them as a way of letting everyone have access, whilst I'd love to let everyone have access, I think that would clearly create some issues from the commissioning perspective. So I think it is important that we go with the spirit of those, but I think both those new indications are really helpful.
Yeah, and then I think, Ian, you were particularly enthusiastic about the dialysis indication. Have you had much experience?
Yeah, no, so we've been certainly starting to use Libre in people on dialysis, and with some quite striking impact. I think in terms of the generic set around guidelines, my take on it from a positive perspective is I think it's made people much clearer of what the guidelines are. Actually, in our own area on the south coast, it probably hasn't changed many of the criteria. with the exception of the psychosocial one. And I have to say, personally, the psychosocial one is the one I've been having some challenge with around this process of assessment, because I think what we have tended to do for previously is to use data that we have for an individual prior to using a sensor, and then make a comparative statement with that. But I think the challenge is we're often comparing apples and oranges when it's the psychosocial. So I think it is one of the challenges for me to think about what is a robust and realistic assessment process under that process.
And I think we've used RMDT particularly for that. I think, some of the other indications, it's absolutely clear, and you can make that judgment. I mean, either someone's testing 8 times a day or more, or they're not. So that's always been quite straightforward. So I think the MDT has been very useful in that sense, in just sense checking those decisions.
And Ian, when people come back to clinic with the data, how useful do you find that?
So I think that the data piece, I think, is something which for healthcare professionals is or should anyway, I think, change the consulting practice of the majority of our specialty over the course of the next few years. I think there are some I's to dot and T's to cross still around the data piece, and I think there have been some potential challenges recently. A lot, I'm sure, of the people dialing in today will know of the recent changes to software updates, both for the handset readers, but also for the LibreView software as well. And I think one of the challenges around that is this rumour that has been out that there may be a disconnect between that software piece and Diasend, which is what we've tended to use routinely in our clinic. And such teaching that there has been around data use in clinic has tended to centre around Diasend in the UK at least, and I think that's probably true of Europe, mainland Europe as well. So I think that the rumour anyway that they may be wanting to disconnect from Diasend, I think is something of a challenge for us, and something that we will need to try and pick up, I think, in national fora to make sure that we are more robust in the way that we actually practice with the data.
Yeah. I think overall for us, we've seen a massive increase in the numbers going through, and I think it'll be interesting to see a year on from the NHS England criteria coming through as to how many numbers actually go through. I suspect it may be higher than 20%.
Yeah, I think that's probably inevitable, isn't it? We were, even with our existing criteria, we were looking at about 20%. So to have some additional criteria over and above that, I think we're almost inevitably going to have more.
Great, well thank you very much. I think this opportunity will move across to start our exercise module. As I said, Rob and Parth can't be here with us just now in Loughborough, but they are online and will be available to take your questions. So please feel free to post questions as the module plays, and then we'll be able to address those questions at the end. Thank you.
Welcome to the Exercise and Freestyle Libre session. My name's Parth Narendran. I'm a consultant in Birmingham and I lead the type 1 diabetes service there. And there we provide a service for people on pumps and continuous glucose monitoring. I also sit on the Daphne Executive Board and I'm also the lead for Daphne at my site.
And I'm Rob Andrews. Like Parth, I'm a consultant. I work in Taunton. I have an expertise in type 1 and exercise, managing elite athletes who have type 1. I'm also Daphne trained to do insulin pumps and continuous glucose monitoring. What we're hoping to do over the next 22 minutes of this video is we're going to talk about what you need to think about before you exercise. We're then going to work on to the options that are available for managing glucose during exercise. Then talk about options that are available for managing glucose after exercise. And through the whole course of this talk, we're going to look at how Libre can help you manage your glucose levels before, during and after exercise. So starting with considering exercise, there are 3 things that you need to think about, and it's worth bearing in mind that across this course we're going to use something called the rule of 3s. That's something that we invented for one of the programs that we teach on called exercise education. So the 3 things you need to consider when you're exercising are: what exercise are you going to do? What time will you exercise? and what has your glucose level been in the last 24 hours.
And just to remind you that all the principles we're talking about are part of an education program we run called the XTOD Education Program.
So moving on to the three things. The three things you need to know about exercise are: what type of exercise are you doing? What will the intensity of the exercise will be? And how long will you exercise for? So the three exercises, and what we've done here is simply divide them into three types of exercise. The first one is aerobic exercise, and like the word, that is a type of exercise that you use air or oxygen. And examples are shown here, for example, cycling your bike or running. The second form of exercise is anaerobic exercise. And like the word says, that is exercise that is done without air or without oxygen. That tends to be explosive and lasts for about 2 minutes. And then the final form of exercise is flexibility exercise. That's there in order to help you become more flexible, and generally is stretching or yoga. Interestingly, if you're going to get good at a sport, you need to have all three components of these. So if you want to be good at a sport, you have to be faster, stronger, and more flexible.
And whilst we've split these sports into three different categories, bear in mind that some exercises can fit more than one category. So swimming, for example, you can either do a sprint swim, in which case there might be more of an anaerobic component, or you can do a long distance swim, which is more aerobic. And then remember, some sports will also have different components of exercise in them. So in football, for example, if you're playing centre forward, you're going to be much more sprinting, so much more of an anaerobic component. Whereas if you're more in defence, it's going to be more of an aerobic component.
So the reason for splitting these into these types of sports are that they actually have differing effects. So what you can see on this diagram is that if you do a flexibility exercise, on the whole what will happen is that your glucose will stay fairly steady. If you're doing an aerobic exercise, on the whole what will happen is your glucose will gradually drift down. And if you do an anaerobic exercise, an explosive exercise, lifting weights, then your blood sugars will tend to go up. If you're doing a combined exercise or a mixed exercise, such as a team event where you're doing both aerobic and anaerobic, your blood sugars can either go up, they can stay the same, or they can fall, depending on how much you're doing of those components.
So for example, if we went back to the game of football, someone who's playing centre forward, their sugar might rise. If you look at that bottom graph, they might be on the upward arrow. But someone who's in defence, they might be falling on that bottom arrow.
The next thing you need to know about the exercise is the intensity of the exercise. And what we mean by intensity is the power that you're having to put into the sport. As the intensity goes up, you'll use more carbohydrate and less fat. And the reason why that's important is if you're using more carbohydrate, then you'll find that you might have to give more carbohydrate in order to prevent your blood glucose falling. So the reason that's important is for different purposes. So for someone who's trying to lose weight, it'll be more useful for them to do a low intensity exercise because it burns more fat. And in someone who's doing a high intensity exercise in the context of diabetes, you'd just be careful to make sure there's more carbs coming on board to ensure there's no hypoglycemia. And then the final thing that you need to think about the exercise is how long you're going to do the exercise for. So as you can see in this graph, what we're showing you is where you're getting the fuel from, either muscle triglycerides, blood fats, blood glucose, or muscle glycogen. And as you go on time, you can see that actually it's the blood level of glucose and the blood levels of free fatty acids that become much, much more important.
So I guess what this graph tells us is that if we're exercising for less than half an hour, or up to half an hour or less, depending on the intensity of course, but up to half an hour, we're not drawing much energy out of the bloodstream. We're generally using what's in the muscle, and therefore it shouldn't affect your blood glucose levels. So now we're going to think about the sorts of things we need to think about for the effective time. So what we're thinking about is how much insulin do you have on board? And In terms of the bolus insulin, remember that'll peak at about 2 hours after, it'll be present for about 2 hours after a bolus. So if you're exercising within 2 hours of a meal, you're going to have quite a large amount of insulin on board, and we'll talk a bit about that in the next slide. The other thing we'd like you to think about is whether you're exercising in the morning or afternoon, and we'll explain why that's important as well shortly. So if we look at our insulin levels in someone with or without type 1 diabetes, our lowest insulin level is when we wake up in the morning. So that's often the safest time to exercise. Then our insulin levels, of course, peak with each meal, as shown in this graph. And then in between meals is when our insulin levels fall again. So that's the second safest time to exercise.
What does this mean practically? What this means practically is that you could try exercising first thing in the morning, and if you do that, you're unlikely to need carbohydrate. The other thing that it says to you is if you do exercise within 2 hours of eating, you're going to be at high risk of your blood sugars going, so you might have to actually take some carbohydrate.
And then why is the time of day important? Well, remember in the mornings, not only is our insulin level low, but also we're most insulin resistant in the mornings. So we're least likely to have a hypoglycemia at that time. The other advantage of exercising in the morning is that if you were to have a hypo, you're more likely to be awake at that time. Whereas if you exercise in the evening, you might be asleep, in which case you'll be less aware of a hypo.
So now moving on to thinking about the glucose levels, again, there are 3 things that you need to think about. The first one is, have you had a low blood sugar or hypo in the last 24 hours? Second thing is, what's happened to your glucose over the last hour prior to you thinking about doing exercise? And finally, what is your current glucose? So going to the hypoglycemia and exercise, there are 2 different types of hypoglycemia. The first one is the severe hypoglycemia. And what we mean in simple terms by severe hypoglycemia is that you've needed someone else's help to manage that low glucose. If that's happened, then you're at very, very high risk of having another low or hypoglycemic episode when you exercise. And what we'd say is you shouldn't really exercise within 24 hours of having one of those low blood sugars that's severe. The other type of low blood sugar is the one that you don't need help. So just a simple low blood sugar or hypoglycemic event that you don't need help. With this, you're at high risk of having another low blood sugar when you exercise, but not as high as if you've had a severe one. So you are able to exercise, but provided you take a few things into account. We would suggest not exercising alone, so don't go off and do a solo swim or do a solo run. Monitor your glucose more frequently and check your glucose overnight.
And just to reinforce the importance of not exercising if you've had a severe hypo in the last 24 hours. So in Rob's clinics, he's now had 9 people who've tried to run the marathon within 24 hours of a severe hypo. None of them have completed the marathon, and 3 of them have ended up in the intensive care unit. So it's really important that that you do not exercise within 24 hours of a severe hypo.
So the other thing you need to think about is the direction of glucose. So although you'll get a reading on your machine saying that it's 6 or it's 8, what you need to know is what's happened in the last 15 to 20 minutes to tell you what that means. Is the glucose falling or is it rising?
And of course that would make a difference. So in this slide, the glucose values are broadly the same, but if you were starting with a value of 9.8 and going up, you might delay having to take carbohydrates during the exercise. But if you were at 8 and on the way down, you might want to take extra carbs at the start.
And to try and help you with that, what we've developed is this algorithm. This algorithm is used on our course that we teach patients, and we've just changed it slightly to add the information from the Libre. So what you can see is it tells you when you check your blood sugar, you look up within the box as to what you should do. So if your glucose is between 5.7 to 6.9, then you would take 15 grams of carbohydrate before starting to exercise. Then shown on the right of the slide is additional information that you would get from the Libre and how you would interpret this flow sheet. So if your blood sugars are less than 6 or more than 15, on your Libra, we would suggest that you go back to the old way of checking your blood sugar, of doing a finger prick test just to confirm that it's less than 6 or it's less than 15, because you're going to have some action. If you're in that range of 5.7 to 6.9, but one of the arrows is up, then that suggests that your blood sugar is going to slightly rise, it's on its way up. So we're saying you don't need to take that extra carb that's in that box. If you're in that same range and the blood sugar is actually falling, then that means that you're at increased risk of you going hypo during the event. So we're suggesting to you that you should take twice as much carb in the first 20 and 40 minutes of exercise. And finally, if it's between 7 and 9, although the algorithm at this point says you don't need to take anything, if the arrow is going down, we would suggest you do take 15 grams of carbohydrate to make sure that your glucose doesn't fall during exercise.
So now we've spent a bit of time talking about the physiology of exercise and some safety aspects. So now we're going to talk about some of the principles we can use to manage glucose around exercise. And here we're going to concentrate on the principles during exercise, and we use this mnemonic called ICE, and it stands for insulin, carbohydrates and exercise, because these are 3 things that can be used to manage the glucose. So first we'll start with insulin. And going back to our earlier figure, remember peak insulins after a bolus insulin following a meal generally lasts for about 2 hours. So if you're exercising within that 2-hour period, we'd ask you to halve the dose of insulin as a starting principle. Now, if you think about it, during exercise, glucose is coming out of the liver into the bloodstream to replenish the muscles, and insulin prevents that. So if you were to take half the dose of insulin, it allows more glucose to come out of the liver to replenish the bloodstream and also to replenish the muscle. And this principle works, of course, for people who are on pumps, as well as for people on MDI with their bolus insulin.
And an example of that is, say that you knew that you were going to exercise within an hour after having your lunch, and normally we would take 6 units of insulin for that lunch, then you would take 3 units and then go and exercise after your lunch.
Now, for the basal insulin, remember that it's often too late to change that around the time of exercise, because you'll have either taken it in the morning or the evening before the morning exercise. So for people on MDIs, there's not much we can change for most situations. However, for people on pumps, we can change it. And here we're suggesting a reduction by 50% of your basal insulin starting an hour before exercise, continuing at that 50% dose, and then back up to your usual level when exercise finishes.
So going back to that example, if you were having lunch at 1 o'clock and you knew you were going to exercise at 4 o'clock, what we'd say to you is that you take your normal bolus of insulin, and then at 3 o'clock, an hour before the exercise, you would change your background rate down by 50%. It would stay there for an hour, then stay there for the exercise and remain after the exercise, and then stop after the exercise. An alternative to changing the insulin is that you could take carbohydrate. And what we term this is X-carb, so that is exercise carb or extra carbohydrate for exercise. And again, a starting point that we would suggest, or a simple regime that we would suggest, is that you start with 60 grams of carbohydrate taken every hour. We don't want you to take all the 60 grams at the start, otherwise your blood sugars will start high and fall. What we want you to do is we want you to take it every 20 minutes. So we would suggest that you took some every 20 minutes. The advantage that you have with the Libra is that you can also make changes whilst you are exercising to make sure that your blood sugars don't fall. And this is another one of those algorithms that you can use. So what's shown on this algorithm is what to do at each glucose level depending on what the trend arrows are. So for example, if your blood sugar is between 5 and 6.1 and you have a trend going downwards, then we would suggest that you take 15 grams of carbohydrate. That's roughly 3 jelly babies. Similarly, if it's between 6.1 and 6.9 and you've got a trend going down or an arrow going down, we'd say that you take 8 grams of carbohydrate. This way you can adapt and make sure that your blood sugar stays steady during the sport.
And then the third approach, so we've talked about insulin, we've talked about carbohydrates, and the third approach is to use exercise itself. And you saw before the different exercises do different things for your blood glucose. So as an example here, we can switch between exercises to control our blood glucose. So during aerobic exercise, as you see here on the first panel, during a run or a bike ride, the blood glucose levels are going to fall. However, if someone switched the exercise, it would put the blood glucose up if they switched to anaerobic. So I have a patient, for example, who when he goes into the gym, if his blood glucose is high, he would start with aerobic exercise to bring the glucose down, and then he'd switch to anaerobic. However, if he walked into the gym and his glucose was a little low, he would start with anaerobic to push the glucose up, and then he'd finish off with aerobic exercise to bring the glucose down. And you can also use this intermittently. So here is someone who on a long run might see his glucose drop through the run, but if he were to put in little sprints in between that, then it's an efficient way of keeping the glucose stable.
And it's very, very powerful, this. It's not a very big sprint that you need to do, so you only need to sprint for 10 seconds. But recently I had a patient that actually rode the channel, didn't use carbohydrates, used this mechanism for propping up their glucose. The one thing you have to remember, though, is that you've done two forms of exercise. And if you think of exercise as a bit like going on a credit card, is that if you do one form of exercise, you've got to pay back once the credit card. If you do two forms of exercise, you've got to pay the credit card twice. So you're at more danger of the blood sugars falling after exercise. That takes us on nicely as to what you do after exercise. Again, there are 3 ways to manage glucose after exercise. And again, we use that mnemonic that we used before, ICE. So ICE is there to prevent you having injury. So you can make changes to the insulin, make changes to carbohydrate, or make changes to exercise. So starting with insulin, as Parth mentioned, we all have a profile of insulin, starting with a low insulin in the morning, then having peaks with each meal time, and then your insulin falling over the evening. What happens to an individual who doesn't have type 1 diabetes after exercise is that they become more sensitive to insulin. Because they become more sensitive to insulin, they produce less insulin because it's able to do the work, and they have lower levels of actually insulin post doing exercise. Patients with type 1 diabetes also become more sensitive to insulin, so we have to try and mimic that post exercise. And one simple way of doing that is to do what we call the 50-50-20 rule. And what that means is that you do a 50% reduction of your normal bolus that you would take for the 2 meals after exercise. You do a 50% reduction of your normal correction, and you do a 20% reduction of your normal evening background, particularly if you've done exercise after 4 p.m. in the evening, over 2 hours of exercise, or some form of high intensity training at any time during the day. If you were on the normal taking background insulin by injections, then you would just reduce that by 20%. If you're on a pump, then we'd ask you to put a temporary basal rate down by 20% for 6 hours from when you've gone to bed.
And this, on the pen, this advice applies to people on standard basals. Well, the ultra long-acting basals, obviously they have their advantages, but we found that with some patients that this, by the time the change is made, by the time the effect comes into place, it's a little bit too late. So in these situations, other approaches such as taking extra carbs will have to be used. And then moving on then, so we've talked about changing insulin after exercise, and now we're going to look at using carbs after exercise. And there's 3 things really. Firstly, in people who do lots of exercise, we've just got to make sure that the daily carbohydrate requirement is being ensured. And it's very common that this is not happening. So just make sure the right amount of carbs is going in for the standard daily requirement. Then on top of that is, do they need some extra carbs or extra nutrition for recovery? And then do they need some extra carbs when they go to bed? So firstly, for recovery, we would say that the recovery food is needed if it's been over 60 minutes of moderate intensity exercise or over half an hour of intensive exercise. We should think about some recovery food. And here we're thinking of food as a ratio of 4 carbs to 1 protein. And the protein, of course, is needed for muscle repair and muscle growth. And the carbohydrates is needed for glycogen replacement in the liver and in muscle.
And for an example as to how much you should use, what we're saying is you should use 1 gram per kilogram per hour of exercise of carbohydrate and 0.2 grams per kilogram of protein. So if you were 70 kilograms, you take 70 grams of carbohydrate and 14 grams of protein.
For bedtime snack, we'd say think about it if there's a concern about hypoglycemia, and particularly in two conditions. One is if there've been a late exercise, so after 4 p.m., and the other is if there's been a long duration of exercise, so over 2 hours.
And then the final thing that you can use is exercise to manage your glucose post-exercise. So exercise can help manage the glucose in 2 ways. One, it can help lower high glucoses when you finish the main exercise you were doing. And the other thing that we know is that the more exercise you do, the more per week, the more sensitive you become and easier it is to manage your glucose. So for example, if you've finished your exercise, say you had done a five-a-side football tournament, then you might find your blood sugars are very high. Rather than correcting with insulin, what you could do is do one of these exercises that's shown on this diagram that tend to lower glucose, such as a brisk walk or jogging. And what that would do would be bring down the actual glucose level and would mean that you don't have to take the extra insulin and be at risk of low blood sugar. And roughly, you need to do about 10 minutes of exercise to move your glucose by about 2.
So just to summarize then, our learning objectives are, what do you need to think about before you exercise? What exercise are you doing? What time are you doing it? And what's your previous and prevailing glucose? Then the other thing we're asking you to think about is, what are the options available for managing your glucose during exercise? So we're talking about insulin, both basal and bolus. We're talking about carbohydrates. And we're talking about using different forms of exercise to manage your glucose. And we're also talking about what are the options available for managing glucose after exercise. And of course here it's back to ice as well. So in terms of reducing your insulin, the 50-50-20 rule, extra carbs, both for recovery and as a bedtime snack, and also exercise itself to manage your glucose. And also we've touched on how the Libra can help manage your glucose around before, during and after exercise, both for looking at your prevailing glucose and looking at the trends. And what we've done here is given you some basic starting advice, which we think is safe starting advice, and more advanced advice can be obtained off our website, www.xtod.org. Thank you.
Thank you, Rob and Parth, for that fantastic presentation. And we've had quite a few questions coming in during the presentation. And so I wanted to start by getting feedback from both Rob and Parth on what they feel the biggest differences are that the Libre has made to their consultations in the clinic with people that are either exercising or keen to exercise.
I mean, it's Rob here. From my point of view, I think that the biggest difference is that you can get refinement much quicker. So in the old days, what we used to do is that we'd see people, they weren't getting as many readings as to what was going on, because obviously they couldn't do it as often. And it took a little while to get things right for a different form of exercise. Now we get much quicker feedback, and through just emails and things, we can make adaptations much quicker, so we can get people's glucoses better around exercise quicker.
Yeah, the ability
so
for... Sorry, on you go, Parth.
No, I was just going to say, sorry we both can't be there, but I was just going to add to what Rob said, but I'll let you finish first, Emma.
No, I was just saying I think the ability for remote monitoring is a great advantage, because the thing that worries me when people are starting to exercise is you want to be able to have regular discussions and support them to get confidence with exercising, and the ability to just be able to log on to LibreView is a great advantage, isn't it?
Yeah, absolutely. So in addition to that, what patients tell us is that the trend is very useful. So previously would say you'd want to be thinking of 2 tests before you start exercise to look at which way your glucose is heading. But now you've got the arrows, and also during exercise it's very useful to see which way and which rate the glucose is falling. So that's the other thing that's very useful with the Libre.
And another question I had for both of you really is, if somebody came to clinic and they aren't used to doing any exercise and they want to run a 10K in 2 months' time, what's the sort of process and what's the approach that you'd have in that situation? And how would the Libre help you?
So what? You go for the first part.
So say in someone who without type 1, there's a standard program of way of starting exercise safely. So that's something that people can type into the internet, couch to 10K, and in that sort of time. So that's one of the things they could look at. Then all the principles we've gone through in the video will apply. So the changes they need to make to basal and bolus. And then as they become fitter, the things that they need to think about are that they're going to get more insulin sensitive. So their basal rates are going to go down, their bolus ratios are going to go down. So they might find, if they're consistent with their training, as they're approaching the event, their insulin doses are lower. And then the other thing, of course, is to make sure that the diet is optimized, so there's enough carbs going in, enough protein going in for muscle building. So those are So apart from the things during the exercise, the insulin changes and carbs they need to think about during exercise, over the duration of the training, they need to think about the other changes I've mentioned.
And that actually feeds in quite nicely with another question that we've had come in, asking, do you have athletes who are on a low carbohydrate diet, and what's your advice in that situation?
So it's very rare to have athletes that are on low carb diets for longer than sort of 3 weeks or so. You get real benefit for training in low carbohydrates because it helps obviously with body weight, but it also helps you to manage your ketones and manage fatty acid burning. But over more than 3 weeks, there's quite a lot of evidence that shows that it affects your performance, particularly if you're doing endurance events. So obviously none of the athletes that are going for times maintain themselves on that, but they find it very useful to dip in and dip out of it to control both their weight and also help with their lipid oxidation. If there are people who are on it, then you have to be very careful, particularly if you're doing endurance events, to make sure that about the ketones and things, because the ketones go up much greater during the race and things, or the long events.
Great, that was really fantastic insights. I'm just going to turn to the panel. I think you've got some questions, Ian.
Yeah, Path, Rob, can you both hear me okay?
Yep.
So a question I often get asked in my clinics is a very basic one with Libre, which is how often should I scan the Libre? And I was wondering if I could extend that question to during exercise. How often do you think it is useful for people to look at their Libre during a bout of exercise?
You can answer part of one.
Yeah, I'll start. So if it depends on the event and whether their glucose are stable before they start and which way it's heading. So all of this will depend on that. And but generally every 20, we're asking people to check their glucose about every 20 or 30 minutes.
That's good.
Yeah, I mean, I think what the evidence shows is that for the first 20 minutes of exercise, and for most people, unless they're elite people, up to 30 minutes, your glucose doesn't really change very much. So So I'd agree in the first bit, you don't really need to do it very much. As you get past the 30 minutes, then you might do that slightly more when you first start, just so you can see what direction things are going in. But what you don't want to be doing is continually looking at it all the time and trying to adapt all of the time, because that can give you quite a rocky road if you then start taking things and you don't wait for the change to happen.
That was a lot. The question I was referring to actually is the issue about those people who are looking almost too frequently, and so are then either doing too much carb loading during the exercise or trying to do other corrections.
Yeah, and the on that flow diagram that we gave, kind of saying how much you take, what you're doing is you're taking it and you're waiting 15 to 20 minutes to see what happens, unless you're in the bit when obviously it's very, very low, because what you want to do is then wait for whether your action has had an effect. If you keep taking it, then you will overcarb.
Yeah, I think so. And I think...
Can I ask you what advice you give if the display shows no arrows either before or during exercise?
So if it's showing no hours and everything, and they're feeling fine, then we would just go with what replacement so they will have worked out a replacement for the exercise. They would just continue with that replacement that they've decided to do. Okay. Does that make sense? So if they start at the beginning and they've decided that they're going to do it, so if they're not doing anything, then for that exercise they decided they don't need to do anything, then they won't do anything. Does that make sense?
Okay. And I think one of the other things we wondered about was, do you get issues with the adhesion of the Libre during exercise? Do you find that there's anything that particularly causes a problem with it staying on?
Yes, me and Parth were just talking about that actually, about swimming and other events and things. So swimming is a difficult one. You don't generally get the 14 days from if you're swimming more than every other day. So that can be a problem, even if you put things over to try and keep it as much as possible from getting wet. And then sweat can cause a problem. Interestingly, a lot of people, if you put it on the inside of the arm, although you expect you probably are going to sweat more on the inside, you don't, because it drips away from your arm. Whereas if it's on the outside, obviously your sweat is held into the actual padding. So actually it gets much wetter if it's on the outside than it's on the inside. So quite a lot of people, I say to them, you seem to have good readings. Actually, if you put it on the inside of the arm, if you're finding that it's not lasting as long, or you're having problems with the sweat, actually you find it lasts longer.
Thanks.
Excellent. Well, thank you very much for joining us for the webinar. I'm sorry you couldn't be here in person, but I'm grateful you've taken time out to answer the questions, which is much appreciated. So we'll perhaps get you back in at the end if there's any more questions come through relating to exercise. But thank you very much. So we will now move on to the next module, which is on glycemic variability from Ian Cranston, in the hope that Pratik Chowdhury might join us in time for his module. So I'll hand over to Ian and his module, glycemic variability. Thank you.
Hello, my name is Ian Cranston. I'm a diabetes physician based in Portsmouth on the south coast. I have a background in clinical research looking into issues around impaired awareness of hypoglycemia, and for the last 20 years or so I've been undertaking clinical practice in an effort to try and introduce some of the lessons we learnt in that research period into routine clinical care, and further trying to educate both colleagues in the healthcare professional field, but also patients treated with insulin, how they can best avoid problems with hypoglycemia. For the last 5 years or so, we've been able to use continuous glucose monitoring, such as Freestyle Libre, in our clinical practice. And I think this has really highlighted some of the lessons that we've picked up around probably one of the most key features around avoiding hypoglycemia problems, which is glucose variability. So what I'd like to do today is talk about what we mean when we talk about glucose variability and what causes it, how one can identify glucose variability, and of course, in the long term, how we can help to try and reduce that variability to improve outcomes. So, Traditionally, we've thought a lot about glucose control in terms of trying to reduce the overall average of glucose levels with measures such as the hemoglobin A1C. And indeed, our goals of care have often been to try and reduce this average to ensure that we minimise an individual's exposure to excess glucose levels, which we know can cause problems for blood vessels. However, if we make this reduction of average the only focus of our care, we know that that can lead to problems by the generation of hypoglycemia if the differences in an individual's glucose levels from one day to the next, which we term glucose variability, aren't also addressed alongside. So, in this panel, we have 4 individuals and their glucose profiles over a 2-week period collected with the Freestyle Libre sensor. Each pair, the top pair and the bottom pair, have got a similar hemoglobin A1C. But we can see that the overall glucose experience of the individuals represented by each panel is really very different. Those on the left-hand side of this graph show clearly much less glucose variability from one day to the next than do those on the right. And although their average of control is the same, it's clear that for any of us choosing what we would like our control to be, we would choose those with the least variability. So, whilst the average of glucose levels is certainly important, and we know that this is something that builds up to our overall risk over time, we have to recognise that the glucose control of an individual is much more than just that hemoglobin A1C average. And so we need to take into account measures of glucose change, or glucose flux, if you like. And these measures naturally fall into 2 categories. The first category is glucose flux that happens in an individual day, which we tend to term glucose instability. And in the graph on the left-hand side of the panel here, we can see that this individual has a very significantly rising glucose level after his evening meal, which then creeps up over the course of the night. By contrast, the other form of glucose flux that we see is the flux that happens between days. So, the profile of an individual day on the left, if it's repeated but with a different form of instability each day, can produce this much larger profile on the right, and it's this variability between the days that causes so much problems from a clinical perspective. And indeed, I would go further than that to say, because we know that it's these flux measures that actually are the sole target and the treatment requirement to avoid hypoglycemia. So, this is that same panel slightly enlarged so we can see it. And the challenge is, we can clearly see that every day in this profile is slightly different. The challenge, of course, is for us to look at this as a single image is very confusing and indeed slightly overwhelming, both to people with diabetes and, of course, to their healthcare professionals trying to help. And so if we are to use these measures of glucose variability effectively, we need to have a different way of looking at them. And that's exactly what's happened by the use of this thing called the ambulatory glucose profile, which in the Libre's own software they call their daily patterns view, which allows us to see multiple days as a much simpler figure. What this panel represents is a dark blue line, which is the median glucose level over the period of the sensor wear. So the median means that half of the values are above, half of the values are below. The dark blue shaded area is bounded by 2 other lines. One is what we call the 25th percentile underneath the median, and one is the 75th percentile. So that between those 2 dark blue lines, we can see a half of the individual's entire glucose experience over the period of the time that the sensor was worn. The light blue shaded areas represent both the 10th and the 90th percentile respectively. So in other words, 80% of this person's overall glucose experience. And in this way, we have a much more detailed picture of exactly what this individual has undergone through the course of the sensor wear. The highest and the lowest 10% of an individual's glucose experience are omitted from this picture, which is a quite deliberate act, because what we're trying to use this for is to look at bigger patterns rather than individual days. And so what we take from that is that the highest and lowest 10% mark, if you like, extremes of an individual's experience, and therefore things that are relatively unlikely to be repeated. So we've talked about variability, we've talked about exposure in terms of hemoglobin A1C. On this figure, what do those two things look like? So effectively, the hemoglobin A1C, or the average glucose level, is shown on this figure by the area underneath the median line. And the two mathematically are virtually identical in that respect. The way we see variability on this picture is slightly different, and the way we see variability is actually how wide the profile is at any given particular time of day. So on this figure, what we're seeing is the half of the individual's experience, and therefore, if you like, it might be described as the usual level of variability that this person experiences at particular times of day. And we can see that that is different at different times of the day. But of course, we also can see a much wider pattern of variability, which relates to the 80% experience, and if you like, the difference between those two being what usually happens at a given time of day versus what sometimes happens at that time of day. And determining the difference between those two things is an important part in us trying to address them for the future. So what we have here on this slide is 4 different profiles from different people. And we can see that the profiles can look very, very different from one person to another. Top left, we have an individual who doesn't have diabetes. And we can see that for this individual, the whole of the glucose experience, when averaged out according to these interquartile and interdecile ranges, is virtually a flat line. Bottom left, we have what we were, if you like, we might be aiming for an individual's glucose control over time who's using treatments to manage diabetes. And we can see that it remains quite flat. It's not as narrow as the individual without diabetes, and the overall position of the line on the graph is slightly higher than that is for someone without diabetes. But this still reflects good control, and we'll talk more about that a little bit later. On the right-hand side of this slide, we can see 2 different patterns of individuals who have far more variable glucose levels. And again, I've chosen 2 patterns deliberately, the top and the bottom panel on the right side here, that show people with very similar hemoglobin A1Cs, but very different patterns of glucose variability, which are immediately discernible on this profile. So, we know that the overall variability from day to day results from a different pattern of instability occurring each day in someone's experience. So one of the things that we need to look at, and you'll see in many of the series of this videos, is what could cause those instability differences on different days. And of course, we have here 2 days where we can see the pattern of glucose on those 2 days is almost the reciprocal of each other for the same person. And we have to then ask ourselves, well, why is that pattern different on the 2 days? When we look at the 2 days in more detail, and you'll see these in more detail in one of the other modules in this series, we can see that it's the same sort of decision making that is available on both days. Overcorrecting high glucose levels, over-treating low glucose levels, meals without insulin, etc., etc. The key, however, is the reason that the pattern is different on the 2 days is that those things are happening at different times on the 2 days. So the thing that drives variability is the difference between the decision making on the 2 days. If decisions are always perfect, it doesn't matter that they're happening at different times of day. If the decisions are, however, less than perfect, then the time of day at which they're happening makes a difference. And of course, there are many, many causes of glucose fluctuation that may happen on an individual day. This is just a short list of those, and again, I think you'll look at these in more detail in some of the other modules in this series. So, That difference from one day to the next, how is that easiest assessed? And of course, long term, with the goal of trying to reduce that variability. Effectively, a plan needs to be made. Although on an individual day trace, you can see instability, to see variability, you need to be looking at a trace for many days. And we normally would recommend a 2-week period from this perspective. And the easiest way to do that is to use the display that is known as the daily patterns display, or the ambulatory glucose profile. And the logical time, at least in my view, to do that is in the gap between two periods of sensor wear, in that hour warm-up period before the sensor picks up again. It's easiest to look at it not on a phone screen or a reader screen, but to look at it on either a tablet or a PC, so that we can see more of the information and in more detail. And the important thing isn't to think about the numbers, but it's to look at the overall picture on that daily patterns profile. And when you're looking at that picture, there's a series of questions that you can ask yourself. The first being, how does this profile compare towards what I would like to have as an ideal? And if there isn't ideal, which parts of the day show the most difference from that ideal? Having decided which parts of the day are important, it's then to ask, what decisions do I make at that time of day? What is going on at that time of day that drives the variability? And then to make a plan to say, what will I do differently for the next 2 weeks than I did the last 2 weeks to try and impact upon that? And in that series of 2-week profiles, one can slowly but surely work towards reduced variability. And of course, this is something that we would hope and expect that your healthcare professional will be able to help you with in conversation as part of that consultation process. So, this is a reminder of that profile that we're aiming for. And effectively what we're seeing on this profile is that almost the entirety of the blue profile is fitting in a target range between 4 and 10 millimoles per litre. And of course, the absolute requirement, if it is fitting within 4 and 10 millimoles per litre, is that there can't be too much variability or day-to-day instability for that to be true. So, this is also one of the profiles you saw earlier on, and this is an individual, and the profile clearly isn't fitting in that 4 to 10 target. So how does the picture need to change in order that it could fit? Because what's clear is we can't just push down this profile because it will produce hypoglycemia. And I think this gives us an important insight into the way that we can manage diabetes more effectively. So the first step in trying to make it fit is to reduce the variability. In this particular case, the vast majority of the width of the profile is produced by that sometimes light blue part of the profile, which usually means that an individual's behaviours from one day to the next are quite different, and it's a case of analysing which parts of those behaviours are causing the day-to-day differences. But having reduced variability, this profile will still not fit in a 4 to 10 target group. And in order to do that, we now need to try and flatten the profile. And of course, flattening the profile means balancing up mismatches between parts of the day when there is too little insulin and parts of the day when there may be too much insulin. Once we produce a profile that is narrower and flatter, the job of getting it then down into the target box is actually relatively straightforward. And for most people who have type 1 diabetes, the step 3 is actually not required. Because if you address steps 1 and 2, step 3 happens automatically. So I'd like to give you an example of that process to finish with, who's a gentleman from my clinic who I saw some time ago now. He's a 44-year-old man who's had type 1 diabetes for nearly 30 years. Sorry, just over 30 years. His hemoglobin A1C has generally run along in the range between 7.5 and 8.5. So not perfect, but actually pretty good. Most recently, 8.3%. He uses a multiple daily dose insulin. He uses Lantus as his background insulin and Humalog as his mealtime insulin. He's what I call a Daphne graduate, in that he has done carbohydrate counting and he's been on the Daphne course to learn how to use his insulin to best effect. And that insulin use is about 28 units of Lantus in a day, and an insulin to carbs ratio of 1 unit for 10 grams, an insulin sensitivity factor of 1 unit for 3 millimoles to correct. On average, he's using somewhere between 50 and 55 units of insulin a day. So the first time he wore a sensor, this is the profile that he achieved. And what we can see from this profile is that actually it's very close to what we would expect his profile to be from his hemoglobin A1C. How do we look at this profile? It clearly differs across different parts of the day. Some parts of the day have greater variability, some parts have less variability. I think for the purposes of this gentleman, it's easiest to look at it through his normal working day. So when he wakes in the morning, actually the profile is quite narrow, and for vast majority of his waking sugar levels are exactly at the target he'd like them to be. We can see that through the course of the next few hours, the profile remains quite narrow, so variability is low, but fairly consistently with a rising glucose level. For the remainder of his day, what we can see is that the profile from about mid to late morning onwards becomes much wider and is running slightly higher than it was when he woke up. The width here relates to the actions and reactions that he's creating, trying to address those slightly higher than fasting glucose levels. And of course, the correction elements that he takes will vary from one day to the next, depending on when he's looked at the data. Once he goes to bed and goes to sleep again, what we can see is that the variability overnight slowly but surely reduces. So one could conclude from this profile that if his sugar levels didn't rise across the first few hours of the morning, he wouldn't have a need to correct during the later morning and afternoon, and therefore his variability would remain quite low for that part of the day. So the action derived from this would therefore be to increase his insulin to carbohydrate ratio at his breakfast meal, and just that action. And indeed, that's exactly the action we took when we discussed this profile with him after his first 2 weeks of wear. He came back a month later, and we can see that his profile looks quite different now. The only change that has been made between these two profiles is that he now takes a 1.3 units for every 10 grams insulin to carb ratio for his breakfast. He still uses 1 for 10, he still uses 28 units of Lantus in the background. And what we can see almost straight away is that this profile has now become nearly an ideal profile. And indeed, he was extremely happy with this and decided to make no further changes. And I'm pleased to say, on his behalf anyway, that his profile really now hasn't changed over the last 2 years. So he has an at-target profile almost all the time. Now, that won't happen for everybody in one step, as it has here. But I think it's an important descriptor of the fact that sometimes the changes that are needed can be really quite small changes to have a big impact upon the overall glucose experience. So, in summary, glucose variability, the difference between one day and the next, is important because it gets in the way of us achieving overall glucose-related goals. Those who have high variability will have a higher hypoglycemia risk, and therefore reducing variability is most often the first step towards improving overall control. The way to see variability from a sensor is to use the daily patterns profile, or ambulatory glucose profile as it's also known. And it I think is a good habit to make to try and look at this at the end of each period of sensor wear. And at the end of each sensor to look at the one change that you might wish to make in advance of the next time that you're looking at the same profile. And of course, if things aren't progressing, that's hopefully where your healthcare professional can come in and help. Thanks very much for your attention.
Thank you, Ian, for that presentation. So before we open up for questions, my update is Pratik Chowdhury is now in the building. Do you want to introduce yourself, Pratik?
Hi, I'm Pratik Chowdhury. I'm a diabetes consultant at King's College Hospital in London, and I think I've got the next 2 presentations coming in a bit.
And possibly a speeding fine for getting here from London so quickly. Anyway,
Let's go.
no, thank you for joining us. So we've had some questions come in for Ian on his glycemic variability presentation. So the first one was, what do I do with my overnight variability when it's greatest overnight? I've started a pump because of the dawn phenomenon, but the variability is significant and the basal rates seem to be going round in circles. What's your thoughts, Ian?
So I think one of the potential challenges with how we treat basal rate insulin is that when you move from an MDI insulin regimen to a pump, we actually are treating basal insulin very differently.
Yeah.
On an MDI, we are assuming that there is a routine average requirement. And on a pump, we can, of course, make that very individually different by the hour, but bizarrely, we assume that that's the same every night, when, of course, what the glucose levels you take into the night may be very, very different, and the behaviours you've taken into the night may be very, very different. So I think one of the issues is around nighttime control, is we need to be able to step back far enough from the individual day to not say every day has to be perfect with a single regimen, but what is my best compromise if I am going to use one rate for every night? And I suspect what we're trying to do is the commonest thing that I see in my clinics, when people are very keen to get that flat line overnight every night and then make a lot of changes which relate to what they think is going on in the night. It's usually what they're taking into the night. That's the, and I think that's actually increasingly true in my own practice with people on MDI as well, actually. A lot of what we see in terms of the overnight hypos, certainly in the first half of the night, relate to what people are taking into the night, not actually their basal insulin, which would have been our traditional advice.
And as people are using the Libre, do you find that they gain a better understanding about the factors that influence their insulin requirements overnight, and do you find they use temporary basal rates more?
So it's interesting, actually. I think that in daytime, no doubt that people on pumps who have access to sensor data will use temporary basal rates more, particularly with that sort of, I'm where I want to be, but I can see I'm slowly rising. I'll add 10% till my next meal.
Yeah.
Or, I'm slowly falling, and I'll take off 10% till my next meal. Interestingly, I think in terms of the overnight temporaries, much less so in people's own, because I think what people are taking into, and it's particularly, I think the challenge is when people are eating quite close to the time they're going to bed, which is, that Western world thing that we do. The challenge with what you take into the night is, do I know that this is going to be something that will take me all the way through the night with this trend? Or is it just, I made a slight miscalculation on this evening's meal, but my usual basal will still be right for my usual basal?
And I guess the other problem is that as you said, people do it during the day because you can still see, what effects it's had when you make that change. Whereas overnight, even with a Libre, you can't.
Yeah.
With an alarmed system, you might get some sense, you might be more comfortable with making a change.
With Pratik sitting next to me, who is certainly one of our preeminent espousers of the partial closed loop systems. I mean, that overnight variability, realistically, if you're aiming to manage it differently on different nights with a pump, realistically you're going to need some sort of algorithm, or you'll never get any sleep.
Yeah. But what Libre has done actually in practice, hasn't it, is that it's shown people the difference overnight. So people were having those variability, having that variability before, but never quite saw it. And if you look at the data coming from Cambridge, which we've seen, of course, is saying that on a closed loop, the amount of insulin it will give you day to day might vary by 200%.
Yeah.
So if on one night you were getting 10 units overnight, if you've done a lot of activity or had a couple of glasses of wine, that night you might only need 5. But if you've had a high-fat meal and spent all day sat in a chair, you might need more. So actually understanding that day to day you need a different amount, but that we don't quite have the algorithm of how to adjust it, that's all contributing to that nighttime variability. But at least seeing it, you can make some sort of judgment. So, alcohol and exercise, dropping the basal overnight, we'll hear about that in the exercise piece as well.
And I think if I come back to what I was showing at the end of that projection, looking at what do I target for my level of variability. The idea is saying, yeah, actually, if you can get most of your profile, which is 80% of your data, fitting in that 4 to 10 range, you're doing a pretty good job. And it may be that it's in the same way that, you know, most of our lives aren't perfect, they're acceptable. And it may be that if we strive for perfection, we sometimes make it worse than it would otherwise be.
So true. So true.
Yeah, and I mean, thinking about how you use the Libre data in clinic, what do you feel is more important, looking at the AGP or looking at time and range?
So I think they tell you slightly different things. So I think that the time in range, I think, is a really important measure, and is we hope, or at least I personally hope, that as of next month there will be an international consensus that says, yeah, that's going to be our main indicator of control, largely in type 1 diabetes, taking over from this idea of an A1C target, in my perspective. But what it doesn't tell you is why it isn't. So the AGP can tell you both of those things, because if your blue part of your AGP, using Libre software anyway, fits inside your 4 to 10 target range, you know that.
You've got 50% time range,
You've got 80% time in range of the whole thing.
Oh, the whole thing,
Yeah.
So you know you're doing really well. Equally, you know which parts of the day aren't doing so well. So, and I say that's what I was trying to get at the end of that video there, which is to say, if you look at that periodically and you say, is this exactly how I would like it to be? If not, where is it most unlike how I would like it to be? Because that's the part of the day, or at least the beginning of that period is the part of the day I need to concentrate on most to think about what other things I could do at that time.
And there's about realistic expectations about time and range. You know, when you mention that we know there's always going to be things that happen that will kick things out of range. And I mean, looking at the consensus document, the consensus that I'm expecting to come out that was agreed is about aiming for a maximum kind of top end is 70% time in range. Will get you an HbA1c of 6.5%, right? And actually, and closed loops currently deliver about 70% time in range. But if you flip that on its head, it means that 30% of the time, which is actually an average of 8 hours a day, you're going to be out of range, but still you can have a glucose control that will render you basically free from complications long term. So there's something about thinking about that in that way as well, saying, you know, it's okay to have a reading that's out of range every now and again, or actually up to 6 or 7 hours a day. It's still compatible with it. You know, we're always going to try and get that better, but it can be up to that amount and still be okay.
Yeah.
And that's the thing I like about time and range. It's a big picture, isn't it? Because I think when you've got all that Libre data, you know, I see people coming into clinic really worried, saying, "Oh, I'm running a bit high here and here." And actually, big picture, you're absolutely nailing this. You know, people who can use it to beat themselves up.
And it is such a good thing to be able to look at, isn't it? Because it does mean something in a way that HbA1c is a bit abstract. People know that it's a number. What does it really mean? Whereas time in range clearly means something. But I think very important, because I find people striving, you know, they're already at 70% and they're striving for 80, 90, and you're going, you know, actually, that's a bit like striving for perfection. You find out it makes things worse in some respects.
Yeah. No, I think you had a question for Ian as well.
Yeah, I was just going to say, do you think there's any, in terms of variability, do you think any of the different insulins have an impact? So I guess particularly, you know, newer insulins like Fiasp and Degludec.
So I think the one thing that probably all of us who look at profiles on a regular basis have picked up in the last 2 or 3 years is, in terms of short-acting insulins at least, the absolute commonest cause of variability that may relate to short-acting insulins relates to the timing of the injection of the short-acting insulins. Yeah. And I think realistically, unless there is pre-dosing of insulin before the meals, you will see enormous variability that kicks in. So I think from my perspective, with the short-acting insulins, it's much more about how you're using the insulin than the actual insulin
I suppose
itself.
One of the interesting things there is we've, and again, I think this comes back to what you've said in your talk about, you know, part of the problem is if you just check before your meal and then, you know, you check your glucose again before your next meal, you've no idea what's happening in between. We've found a cohort of people where Libre has demonstrated they would benefit from switching to Fiasp, and they've done really well having switched to Fiasp.
Yeah, we've done a similar, we in order to get Fiasp onto our local formulary, in fact, we needed to do an audit with CGM to show that there wasn't a risk that they might dip early. And actually what we showed is that overall, the number of hypos people had with using Fiasp was far lower than the number that they had using Novorapid, on the basis of the fact that they weren't trying to correct too late. And correcting too late is another thing that it brings in huge variability. I have to say my answer in relation to long-acting insulins probably is slightly different, because I do think that different long-acting insulins suit different people better or worse.
I was going to say the same thing. Yeah.
And so I think that it is sometimes worth looking around for the right long-acting insulin, and I don't want to particularly do a pharmaceutical comparison, but I think we have 3 long-acting basal insulins that are routinely available at the moment, and I think I would say in my clinic there are people for whom one of those is better for each of them.
Yeah.
And I guess if you've got a more stable lifestyle and you want a more stable insulin, your doses are going to be similar every day. You'd choose one of the once daily ones. If you're the sort of person who actually has great variability in the amount of steps you do, have sports on some days, or alcohol on 2 nights a week, where you need to be able to drop that insulin on some days, a twice daily shorter acting insulin may be better.
Absolutely agree. And I think the logical extension of that obviously is the move over to and actually I'm going to use a pump for my basal insulin, because then I can have it very variable if I'm wanting to look at that.
No, I think that's excellent. Well, thank you very much for your comments. We'll now move on to the final module, which is from Pratik Chowdhury on understanding trend arrows. And after that, we'll be able to take more questions, so feel free to post them through the webinar. Thank you.
Hi, I'm Dr. Pratik Chowdhury, and in this video, I'm going to be giving you a little bit of information about how to understand and use the arrows that you see on your Freestyle Libre device. I'm a senior lecturer and consultant in diabetes at King's College Hospital in London. So we've termed this video Advanced Libre Use, and I think people would probably want to come to this once they've got the experience of using the Libre for a few weeks. The learning objectives from this video are to understand what those arrows mean and give you some ideas on how you might use those arrows to make some decisions or to change the decisions you normally make, and how to use these data with Bolus Advisor apps, and we'll talk briefly about that as well. So when you first start using a Freestyle Libre device, you get a lot of arrows, and this extra information for some people can feel a bit overwhelming. We feel there's a need to understand, when you see that arrow, how quickly your blood glucose is actually changing. To avoid overreacting to that glucose, we've certainly seen some patients, when they start using the Libre, overreacting, causing their blood sugars to get worse. And if you can understand how fast your glucose is going to change based on the arrow, that might help you make a plan and be strategic about when you should look at the data to make some really useful decisions. So this table gives you a bit of an idea about what the arrows mean, and I'll go through this slowly. So the first arrow that you might have is one that goes straight up. And in technical terms, this means the rate of change of glucose is more than 0.11 millimoles per minute. On the whole, that means that you're going to go up by 1 millimole on average in about 7 minutes. It can be between 5 to 10 minutes, but the average is about 7 minutes. I think an interesting way to think about, or a useful way to think about how to use that information, is how far you will go in 30 minutes. And if you've got a straight up arrow, you're going to go up by at least 3, and on average by about 5 millimoles per litre. If you've got the oblique arrow, that means the glucose is changing by between 0.11 and 0.06 millimoles per litre. So it's going to take you an average of about 15 minutes to change by 1 millimole. And if you think again, where are you going to be in about 30 minutes? You're going to be about 2 or 3 millimoles higher than where you are now. If the arrow is flat, it means the rate of change is less than 0.06 millimoles per litre. It doesn't mean that you're not changing, it just means that you're changing very little. And so you may change by 1 millimole over about 20 minutes or so. And in the next half hour, you're unlikely to be more than 2 millimoles away from where you are. So now, if you've got a flat arrow, that means the blood glucose is changing at less than 0.06 millimoles per minute. So that means that over the next 20 minutes, you may actually change by about 1 millimole per litre. in the next 30 minutes, but the change is going to be less than 2. So it doesn't mean that your glucose is absolutely stable. There is a little bit of change, but it's going to be relatively stable over the next half hour. Now, if you've got the oblique downward arrow, again, it means the same. The glucose is changing by between 0.1 and 0.06 millimoles per minute. So you're going to go down by 1 over about 15 minutes. It could be between 10 to 18. And you're going to go in half an hour, you're going to be between 2 and 3 millimoles lower than where you are now. And so you can use that information to work out if your blood glucose was, say, 7 and falling, when you should rescan again. And if you've got the arrow going straight down, of course, that means you're falling rapidly, and you're falling by more than 0.11 millimoles per minute. So it's going to take you, on average, about 7 minutes, but certainly short, maybe down as less as 5 minutes to fall by 1. And in the next half hour, you're going to drop by at least 3, and on average, about 5 to 6 millimoles per litre. And so if you look at Libre data, of course, in the past when you were doing your finger pricks, most of those readings were pre-meal. And with the Libre, most of the information it gives you is after meal. And so you can start thinking about how to use that data to make proper decisions. Because a blood glucose of 12 will lead to a different action if that's before a meal, maybe a different action if it's 1 hour after a meal, if it's 2 hours after a meal, or 3 hours after a meal. And that's what I'm going to try and discuss a little bit later, as this glucose kind of has this bump of rising rapidly after a meal, then slowing down, maybe flattening out, and then dropping down the other side. And it's about understanding what those arrows and blood sugars mean at different times post-meal. When you've got the Libre, one of the challenges people have is expecting their blood glucose is going to be flat all the time. And I think it's really important to have realistic expectations about what you're going to see, particularly post-meal. Because even after you've made you weighed your carbs, your carb ratio is correct, your correction dose is correct, your basal is correct, there's still a large chance that your blood glucose is going to be off target or not quite where you'd like it to be. When we've looked back at patients who've got an HbA1c of 7% or 53 millimoles per mole, on average, they have about 60 or 65% of their Libre readings between 4 and 10 millimoles per litre. So even those people who are at target, if you like, have got about 30% of their readings that are high, above 10, and maybe 5 to 8% that are below 4. And one of the analogies or things that we use to explain this to people is every time you take a bolus or a shot of quick-acting insulin, imagine you're teeing off on a golf course. So you're going to calculate the dose, work out what the right dose is to take. But even the best players, or even if everything is right, sometimes you're going to overhit and have a hypo, or sometimes you're going to not take as much and your blood sugar is going to remain high. And I'll talk you through that a little bit later. If you can get between 60 to 65% of your readings between 4 to 10, we think you're doing a fantastic job. So just to explain that golfing analogy a little bit better, as you say, if you've calculated your dose and you've taken the insulin, the blood sugar is going to go up a bit and it's going to come down. If you can land it near that flag, let's say your target is a blood sugar of 6, that's like a hole in one. And even if you're a fantastic golf player, there's an element of luck involved with that. If you can land the blood sugar between 4 and 10, at least 60% of the time, that means your settings are probably in the right ballpark. That means you're doing really good, you're really good at carb counting, and your carb ratio and basal settings are probably very close to where they need to be. Even then though, sometimes you're going to take the right dose of insulin and it's going to end up in a hypo. For that moment in time, on that day, it's going to be a little bit too much. And of course, when you treat the hypo, blood sugar is going to up and down, it's going to be a bit messy for a while after. And that might happen, we think, even if you do everything you can, up to 5% of the time. About 30% of the time, even people who have really fantastic control might underhit. So you've taken the right dose, you think you've calculated the carbs correctly, but on that day, at that moment in time, that insulin is not enough. And you might have to have a look where your blood sugar is and take an extra nudge or an extra correction to get you back on target. And again, if that's happening between 25 to 30% of the time, I think you're doing fantastic. So just take that a little bit further, if you like. It's how you use the blood sugars at different times. So if you look in the post-meal, a key time is the 1 hour post-meal glucose. That's generally the time when your blood glucose is the highest after a meal. So an hour after you're likely to be rising, and how far it rises generally depends on how early before your meal you're able to take your insulin. If you take your rapid-acting insulin just before or just after a meal, the average rise of glucose is between 8 to 10 millimoles per litre. That's 8 to 10 higher than where you started. So here, if you started with a blood sugar of 6, an hour later this person's blood glucose is now 16.5. Now, if you see that high reading and need to correct down, you've got to remember that the insulin will only start really working a half an hour later, and you might be at risk of hypoglycemia later on. If you take your insulin 15 to 20 minutes before your meal, the average rise is about 3 to 5 millimoles. So it makes a huge amount of difference. And so you can see here blood glucose was in range pre-meal, the patient had a meal, and now an hour and a bit later, blood sugar is flat and at 11, so it's only risen by about 4 or 5. Now, of course, it isn't always possible to inject 15 minutes early, but it's important to do so whenever possible. Every time you do it, you're buying yourself some A1C for free. Now, if you look at where you are at 2 hours after a meal, generally your blood sugar should be falling. If you took the right amount of insulin, 2 hours later, you should be coming back down into range. If you're still rising, you might have underestimated the dose at that time. If your blood sugar is below 6 already at 2 hours, you're going to be at risk of hypoglycemia and you might want to take some preventive carbs. For example, in this example here, the person was in target pre-meal, had injected early, see went up by 2 or 3, and is 2 hours later is coming down, is showing 5.6 with the down arrow. Now the insulin they took, it's still got an hour and a half to run. And if you look at that oblique arrow, as we saw before in that table, you're going to drop by between 2 and 3 millimoles per litre. So at the end of that, you might be at hypo. Common causes for this could be that you overestimated the carbs that you were going to eat, or maybe you did more activity than you thought, or you've had previous hypos in the day. In this scenario, you might want to take, again, a small amount of carbs just to prevent the fall. We would recommend if you're below 6 and just have the oblique arrow, maybe 4 to 5 grams, so 1 jelly baby or 1 dextrose tablet is probably enough. If you've got the straight down arrow and you're already below 6, again, remember, if you're falling straight down, your real blood glucose could be up to 1 or 1.5 millimoles lower. That's a scenario where we think you might want to take a little bit more, maybe 8 to 10 grams, a couple of jelly babies or 2 dextrose tablets. Again, before you take action, do think how much insulin on board do you have? Have you done any recent activity? If you've got a high dose of insulin on board, or you've done a lot of exercise, you might need to take more carbohydrate to prevent that hypo. And this is just an example of what happens if you don't do that, in a sense. You can see here the blood sugar was a little bit high. The patient had a meal and a correction dose. You can see the blood glucose went up and then came really fast down. You can see that little dot, which shows the patient scanned, but maybe didn't take any action at that point. When they scanned, the glucose was about 6. And you can see that it dropped down about 10 minutes later. It was hypo, at which point, of course, that person was feeling symptomatic and took maybe a little bit more carbs hypo treatment than they should have at that time, and the glucose went back up again. And that can sometimes lead to this roller coaster effect. Something we often say to patients in clinic is, if you're falling down and you're dropping below 6, a dab of the brakes, maybe 5 grams of carb might be enough to prevent hypoglycemia. If you don't do it then and leave it lower than when you're down at 3 and you're feeling hypoglycemic, often then you're going a U-turn and you're going to bounce back a bit too high and kind of get on that roller coaster. So we've talked about the 1 hour and the 2 hour glucose. Now moving on to the 3 hour glucose. You can see here the person has had lunch at 1 o'clock. And in this example, they took 70 grams of carb and took 8 units of insulin, which was their meal and their correction. And now about 3 hours later, the sugar is 15 and flat. Now, of course, they're not planning to eat till about 7 o'clock when they get home. And it's 3 hours since their last insulin bolus. So some of that insulin is still working at this point. And you need to think about that when you're working out if you want to correct that 15 or not. If you are in that scenario and you think, I'm 15 and I want to do something about it, we think there's 2 things that you might think of. The first is to use a Bolus Advisor app that understands how much insulin on board there is and helps you does that calculation for you. If you don't want to use that or don't have one, a simple rule of thumb that gives you a safe dose is do half the correction. So if normally the correction dose from 15 down to 6 would be, and drop by 9, so your correction dose would be 3. In this scenario, you might only take 1.5 units. So just be cautious if you're correcting post-meal. 2 of the apps that we routinely use that allow you to put in all your settings and use the Libre data and have the insulin on board information on them are the My Life app and the My Sugar app. And so have a look at those and see if discuss that with your healthcare team, and you might find those useful. The way these would work, this is the My Life app. You can see here the example is blood glucose is 14.7, so the correction dose for that individual was 2.8. They're having 56 grams of carbohydrate, so their meal bolus is 7.1. If you've had some insulin on board, as in the previous example, then you'd show something in that insulin on board category. And if there's a unit of insulin on board, then the suggested bolus would not be 9.9, it would reduce to 8.8, and that helps you avoid stacking. So just to recap, I think the blood sugar at different times gives you different information, and I call this the 1, 2, 3 rule. So the 1 hour glucose tells you, did you take the insulin early enough? If you're high at this point, really think twice before you do something, because the glucose is likely to turn around and start coming down anyway. So the 2 hour glucose tells you if you took enough insulin. And if you're high at 2 hours and you're not coming down, then that means you might want to think about doing a correction at some point. Even at that point though, you might be dropping and you might want to wait what's happening. If you're already low at 2 hours, that could lead to hypoglycemia, and so that's a good time where you might want to take that preventative dose of carbs. There's not much corrective action you're going to do before the 2 hours, and so often I'd say there's not much to be gained by watching the glucose rise and fall, as that can be quite worrying. But between 2 and 3 hours is a good time to have a look, because that's when you're going to make a decision where either you're going to correct because you're a bit too high, or you're going to take some preventative carbs because you're dropping too fast. Now, of course, you also get the arrows pre-meal. And I'm going to talk a little bit about what rules or ideas there are of how you can use that information to fine-tune your bolus dose with an effort to keep your blood sugars between that 4 to 10 margin more often than before. As a rule, if pre-meal your blood glucose is going up, you're going to want to add some insulin to the bolus to account for that direction and rate of change, and to account for the fact that you're going to be, by the time the insulin gets going, you're going to be a bit higher. If your blood glucose is dropping, you might want to subtract some insulin, again, to account for that rate of change in the insulin. In the literature, we found that there's about 3 different ways that people have tried or suggested for you to use that. The first is what we call the ISF, or the correction rule. And here, based on what your total daily insulin is or your correction factor is, you would add or subtract a fixed amount of insulin from the calculated dose based on what the arrows are saying. The second rule that some people use is what we call the predicted glucose rule. So if you've got an arrow, you can predict where your blood sugar is going to be in about half an hour when that insulin is going to get going. And so instead of using your current glucose to calculate your dose, use the sugar where you're going to be in 30 minutes to calculate the dose. And the third rule is the 10-20% rule, which means that you either increase or decrease the amount you've calculated by 10 to 20%, depending on the arrows. So I'm just going to go through some examples there, and you can see if you think this is something that you might want to try. So the first rule is the ISF, or the insulin sensitivity factor rule. And so this table just tells you what you might do if your ISF is between 2.5 to 4 millimoles per litre, and that should cover most people. So again, if you've got an arrow going straight up just pre-meal when you're taking your insulin, you do your normal calculation based on the amount of carbs you're going to eat and what your current blood sugar is, and just add 1 unit to whatever's calculated and take that. If you've got an oblique arrow, instead of adding 1 unit, you just add half a unit. If you're flat, again, you don't need to make an adjustment for the arrow, and just take the dose you'd calculated based on your food and your current glucose. Similarly, if your blood sugar is coming down with an oblique arrow, and let's say you'd calculated a dose of 6 units, just take half off it and take 5.5. And if you're coming down by a straight arrow down, then you'd subtract 1 unit from your calculated dose. For those patients who are a little bit more insulin resistant, so they've got an insulin sensitivity factor of 2 or below, or a total daily dose, that's when you add up your background and all the quick acting that you take. If that's more than 60, then you might double those doses. So for a straight up arrow, you'd be adding 2 units, and for an oblique arrow, you'd add 1 unit if you're going up. And for those people who are on very little insulin, they're quite insulin sensitive. If your insulin sensitivity factor is greater than 5, or your total daily dose is less than 25 units, then you'd halve that. So you'd take a quarter of a unit if for an oblique arrow, and a half unit more if you're going up with a straight arrow, and a quarter unit off, or 1 unit, half unit off if you're falling down. Of course, you can't do that with pens, and you might just use that information to round up or down the dose you're going to take. So this is just a worked example. This is someone whose blood glucose is 9.2 per meal and is going up with an oblique arrow. Their usual insulin carb ratio is 1 unit for 10 grams, and their sensitivity is 1 to reduce to by 3. If they're having a 40-gram lunch, then you've got 4 for the food and 1 for the correction. That's to take you from 9 down to 6. So the total calculated dose is 5 units. Now, because you've got an oblique arrow up, you'd add half a unit to that and take 5.5. The second method is the predicted glucose method. So here, if you've got an arrow that goes straight up, we know that in the next 30 minutes, you're going to go up by at least 3.5, and the average is between 4 and 5. So you just add that, you just calculate your dose based on a number that's 5 millimoles, 4 or 5 millimoles higher. If you've got an oblique arrow, you're going to go up by between 1.6 and 3.5. So you take the average and you'd adjust up by 2.5. If you're flat, you're going to change by less than 2 over the next half hour. So you can just use the blood sugar you've got at that moment. Similarly, if your blood sugar is coming down with an oblique arrow, just adjust down by 2.5 millimoles. If you're going straight down, adjust down by 4 millimoles. So again here, similar sort of scenario, blood glucose is 9.2 but going straight up. So lunch is 40 grams, so in 30 minutes we would expect the glucose to rise by at least an average of 4. So instead of using 9.2 for our calculation, we'll use 13.2 for calculation. And so the calculated dose would be 4 for the food and 2.4 for the correction, which would take it to 6.4 units. Again, if you're using a pen, you'd round that out to 6.5 units or 7 units if you've not got a half unit pen. The third rule is a 10 to 20% rule. And here, if you've got a straight arrow up, you do your normal calculation and add 20%. If you've got an oblique arrow, you just add 10% to what you've calculated. If you've got an oblique arrow down, subtract 20%, and if it's going straight down, subtract 20%. Now, of course, we've got to remember that a lot of these rules were created and used for people using pumps, which is why they're going into decimal points. If you're using a pen, if you have a half unit pen, you can round to half units. If you've got a single unit pen, you'd round it to the nearest number that you've got. So again, that same example, your blood sugar is 9.2 and it's going straight up. So 40 grams of carb, so 4 units for the food. Your sugar is 9, so that's a 1 unit correction. So your calculated dose is 5. If you've got a straight up arrow, you're going to add 20%. So 20% of 5 is 1. So you'd add 1 more to that. So your total dose would be 6 units. Now, which method to use? There's 3 different methods, and we don't particularly want to confuse people, but do want to give people the option to choose the one that works best for them. So again, if you think of this scenario where the blood sugar is 13.7 and rising rapidly, if you'd use the 10-20% rule, you'd end up with 7.9 units. If you'd use the ISF rule, where you're just adding a unit to the calculated dose. So the calculated dose was 6.6 here for the meal and the correction. So you're adding 1 unit to that, so you're getting 7.6 instead of 7.9. And the third option is a predicted glucose. So it's going straight up. The glucose is 13.7, so you're going to add 4 to that and do the calculation based on 17.7. And that would give you 7.9 units as well. So if you've got a bigger meal, and this is that same sort of glucose, but for a 80-gram carb meal, you can see that on the 10-20% rule, you get a bigger rise because it's a bigger meal. So it's 12.7 units. And the ISF and the predicted glucose method give you, again, very similar numbers, 11.6, 11.9. Once you've rounded them out, as you can see, there's not a lot of difference between them. So although they give slightly different results, it's not an exact science. On the whole, if you're rising, you want to take a bit more. If you're dropping, take a bit less. And for simplicity, I think we would advise just using the ISF one, where you're just adding a half or 1 unit to what you're eating if you're going up, or taking that off if you're coming down, and keep things simple. So just to run that, an example here of someone. This is someone who, as you can see, blood sugar was pretty stable through the night, was just around about 10 pre-meal, and they'd had their meal, and the blood sugar is now 18.1, and it's stopped rising. So what should we do? Well, as we said, this is the 1 hour glucose. So at this point, the insulin you're taking for the meal hasn't quite kicked in. Because it's risen by about 8, we can suggest that maybe the gap between insulin and meal wasn't big enough, and we would expect the glucose to fall. So if we wait and see, and now just see what happened 2 hours later, you can see 2 hours later, 4 hours later, in fact, the blood glucose is now back in range. So not correcting at 18, the glucose has come back down into range. If the person had corrected at that point, they would have probably been hypo at this point and had to treat that, and then that might have caused the blood sugar to go back up again. So in summary, I think the best times to scan are, of course, pre-meal, because that's going to help you calculate your dose. And if you want to, you might consider adding a little bit if you're rising, or taking some off if you're coming down. There's not much you can do for the next 2 hours that's going to change that trace. So the next good time to measure would be between 2 or 3 hours post-meal. If at that time you're pretty high, you might want to take a correction, but you must consider the insulin on board. If at 2 to 3 hours later you're a bit low, you might want to consider taking some carbs just to soften the fall and flatten things out. If you've got a high rise in glucose that's going straight up, think about where you're going to be in 30 minutes. That's by the time the insulin you take now is going to work, that's where you're going to be. If your glucose is falling, people I've seen tend to feel it's more useful to think how long it's going to be for you to reach hypo levels. So if you're at 6, that might be how long is it going to take you to fall by 1 by the time you get to 5. And that might be 15 minutes if you've got an oblique arrow, or 7 minutes if you've got a straight down arrow. Small doses of carbs, dabs of the brake prevent hypoglycemia. And again, you can adjust the rapid acting insulin based on the arrows pre-meal. Thank you.
Thanks, Pratik, for your presentation. That's excellent. We've got a couple of questions that have come through towards the end of our webinar. So the first one I'd like to open up with is there a possibility that the arrows are wrong?
I suppose with every technology, you've got to assume that there is a potential for error. And I think we've covered this in some of the earlier seminars, that if you feel that the reading you're getting on your sensor doesn't match with your sensations or how you feel what it should be doing, then you must always double check. Because we know that, for various reasons, for example, at night when people lie on the sensor, we do get these sensor dropouts, which we call sensor compression artifacts. They can cause kind of false lows. Towards the end of sensor life, again, sometimes you get it dropping falsely when you might be going up. So I think there's that caveat that if you feel that the sensor isn't reading what you think it should be, or you're feeling hypo and the sensor isn't doing that, always double check with a finger prick.
Yeah. And have you got any comments on the accuracy of the Libre in different glucose ranges?
So there's data out there about the Libre, and I think one of the things I've seen with patients and the experienced people come back to me with is it does seem to be quite sensor related. So you can get some of the sensors which kind of really on spot, and people are doing finger pricks and they're very close. And then there's the odd sensor that comes out that's maybe a couple of millimoles higher or lower. Now again, in the broad picture, it doesn't really matter, because over the course of a year, that's what your glucose control average is out at. So if it's a millimole or a millimole and a half out, it probably doesn't make a huge amount of difference. At the low end, we know that occasionally, again, with Libre, sometimes they can read a bit lower than you normally are. So you can see a lot more hypos than you're really having. And so if you are low, again, it's sometimes worth, if you're not feeling hypo, to double check. So I think the accuracy, broadly speaking, though, the accuracy that's published across the whole spectrum is, it's measured by something called the MARD, or the mean absolute relative deviation. And broadly speaking, that means that most readings are within 10% of what a finger prick reading would be. And that's generally how we can interpret that.
And you'll be aware that in April they updated the guidance to include women that are pregnant.
Yeah.
Now I know that from April next year we're going to be CGM in pregnancy for all women that are pregnant, but in the meantime, until we've got access to that across the board, we'll be looking to use the Libre. So I know, Peter, you do a lot of pregnancy clinics. Is there specific advice you give around Libre accuracy in pregnancy?
So we know it is accurate in pregnancy. So we've had a study that confirmed its accuracy in pregnancy. I think, as Pratik's, I mean, obviously you're wanting to keep to a tighter glycemic range. So I think if you think that it might not be reading that accurately, we would certainly encourage women to be checking at least once a day to make sure that they're in range. I would encourage them probably to check more than that. I think there are some shortcomings of the Libre in pregnancy in that because the glucose range you're aiming for is tight, it predisposes to hypoglycemia and you don't pick it up if you're using the Libre. And whereas if you have real-time CGM, which hopefully we're hoping that everyone will be using that in pregnancy next year, as of April next year, that just gives you the certainty around alarms. I think also you may not pick up that glucose is rising, and equally you want to stop those larger rises, which day to day with the Libre is fine, but perhaps is not so good in pregnancy. So I think we start all our pregnant women on Libre. Quite a few of them then swap over to real-time CGM, where we feel that it's just not giving them. Yeah.
But I think the other thing, thinking about the original question about accuracy and arrows, it's important to remember that the presentation's been about arrows, but of course there are 3 pieces of information that are on the screen at any given time: the number and the arrow, but also the line. And remember, the line is made up of 8 hours worth of the sensor reading.
Yeah.
So looking at, does what you can see on the line at the bottom of the screen tie in with what you're seeing on the arrow at the top, should allow you to have a greater degree of confidence in the arrow if the two are agreeing with one another. Do you agree?
Yeah. And the other question that's come through is, with you being a hypoglycemia expert, what is your feeling about using the Freestyle Libre in people that have got impaired awareness of hypos?
So I think it's to some extent slightly controversial, if you could say that. So there's no doubt patients who've got impaired awareness of hypoglycemia who gain benefit from the Libre, and that's primarily through how often they're scanning, and they're scanning really frequently, so they pick up the time when they're going close to hypoglycemia, and they can use that data to avoid it. Yeah. Now, there was a head-to-head study done by Professor Nick Oliver from Imperial, and they took a group of patients who had impaired awareness and compared the use of Libre with the use of arrows, and certainly the time spent in hypoglycemia was less with the arrows. And I guess one of the major differences would be when the person is asleep or not scanning or not able to see, when the alarm would pick up in that scenario. So if you've got someone who can recognize their hypos, if you feel hypo, you're going to scan and see where you are and you can treat it. But if you've lost that awareness, unless you're scanning really frequently, then you might miss some of those hypos. So certainly there's a theoretical benefit, and the data suggests some benefit of having the alarms in that scenario. But again, it's a choice of the individual, and some people don't like the alarm systems, too many alarms, and they like to be in control that the Libre gives. And there's certainly people that we've come across and had in clinic who had probably a milder degree of impaired awareness where the Libre works. If you've got complete loss, I think certainly we would be encouraging people to use a system with alarms.
I think it's where actually there's some variability in awareness. So some of the time they're picking up, some of the time they're not. I think they're more likely to find the Libre helpful than the person who just doesn't pick them up at all, where I think alarms are crucial.
It's crucial, yeah. So if someone comes with complete loss of awareness and they're getting readings down to below 2 millimoles per litre without sensing them, I think that sort of person, with a nice guidance, would be eligible for a sensible alert. And we use the gold score, like I think many of you use, which for those of you not familiar with that, ask a very simple question. How aware are you of your hypos? 1 meaning always aware, and 7 meaning never. And if you're scoring around about 4 or 5, that's a sort of, people are in the process of losing their awareness. That might be where Libre really pulls them back and has a big benefit. But if you're on the bottom end of that 6 or 7, I think, you probably, if you're using Libre, you might get some benefit, but you're still at risk of falling through the gaps and having a severe hypo. whereas a sensor with alerts might
It's
prevent that.
interesting. I mean, I think we found it particularly useful in the 3.5s because we somehow people always seem to want to put a
middle,
half,
yeah.
you know. So the 3.5 to 4,
middle
it,
bracket,
it seems to. I actually find, you know, once you're getting down to 4 to 5, then you know, alarms are.
And I think the duration probably matters as well, because if you've gone through a period and your insulin requirements have changed and you've had a run of more frequent hypos, I think starting to lose awareness and getting on top of that and really pushing down that percentage of time hypo to the minimum level to get their awareness back. But whereas the people that have had impaired awareness for longer, I find a bit more
Yeah, no, I think that's
challenging
absolutely
to get it back.
Probably also worth commenting, isn't it, that the sensor, whether it's got an alarm or not, is not the thing that stops you going hypo. It's what you do about the changing glucose level. And I think there are a lot of people who appear to gain a false sense of security from watching it go down, rather than doing something about it as it goes down.
And that was the thing that I was talking about in the presentation about, you know, traditionally people are taught that if your glucose, you know, once you get below 3 or 3.5, that's when you treat. And I think things are different now with the sensor, because the example I giving in clinic and I gave in the presentation is, if you're sitting in the middle lane of the motorway but pointing towards a crash barrier, you don't wait till you crash before you do something. And so once you're below kind of 6 millimoles, and if your arrow is saying you're falling, and as Ian said, if you look at the back trend of the arrow, and you know you've got some insulin on board, you can do something then with 5 or 10 grams of carbohydrate, 1 or 2 jelly babies to prevent the hypo. And this trend of, you know, with Libre data now, the kind of idea of microcarbing and microbolusing and using small frequent corrections to stay within the middle lane, within range, is kind of becoming a new way of managing type 1 actually.
And you look at the Medtronic SmartGuard system. I mean, that's absolutely, you know, when you first start using it, you explain that it's going to shut off insulin
Very high,
you know, 6 to 7. You know, I think the person using it thinks, really? But actually, of course, we know that works really well. And I think it is getting used to the fact that the important thing is where you're heading and how quickly you're heading in that direction. And if you can preempt that, that's much better than...
Yeah, and there is something about, you know, patients who go on to Libre, you know, there's many patients who kind of get the hang of it and work out, but I'm sure you've also seen patients who kind of see that up arrow straight away and feel the urge, you know, that up arrow is quite anxiety generating, isn't it? I've got this straight up arrow, I've taken insulin, but I better take some more. And then you get the straight down, I'm going to crash and hypo, and it's just as you said in the previous presentation, sometimes overreacting those arrows can make things worse, and those patients might get disillusioned early on in their Libre journey and not quite get the full benefit. And so before starting, it's quite important to have that plan of what am I going to do and what does the arrow mean at kind of within the first hour of taking a meal, at 2 or 3 hours later, different values.
I think it highlights, doesn't it, this idea that the way in which one uses insulin is a mixture of reactive to what's going on now, but also proactive to knowing what you usually need. And I think some people with a sensor will start to rely much more on the reactive process, which of course, talking about the partial closed loop system, is of course exactly what they do. The difference being that they never take their eye off the ball, the closed loop.
No, that's right.
Whereas if I react to something now, chances are I'll then forget about it for a couple of hours before I do something else. Whereas
and I mean, I in the introductory module, I talked about the fact that actually this is, you know, you get a lot of data. The temptation is to react. Do you have and we often say to people, you know, the first sensor, just look at it, look at the information, you think what you might do, and then look at what happened and would that have been the right thing to do. And so it's really difficult, I think, to use a sensor and not react. But I think if you can, that first time you use it, that first sensor, if you can just hold back and actually see what happens and get a feel for what it all means, I think that can be really helpful.
Really sound advice,
Yeah. We've had another question come in here when we're talking about access to CGM for people with problematic hypos. Not always a choice of the individual. Unfortunately, a hospital won't consider CGM for me. Scanning 30 to 40 times per day. I can't scan when sailing, cycling, or especially racing. So I wonder, for the audience, if you want to just run through the criteria for CGM. Now, we know that not all areas in England provide CGM in accordance to the guidance, but do you want to just explain what the criteria are for CGM?
So broadly within the NICE guidance, and Peter kind of was part of that committee that wrote the guidance, of course. So if you've got impaired awareness of hypoglycemia, you've got disabling hypoglycemia, so you can't recognise your hypo, or you've had previous severe hypos, and certainly within NICE, you're entitled to CGM. A big change that's happened recently has been that there's been a ruling about where the funding for CGM should come for that's helped certain areas get access to CGM. We've all been involved in the Diabetes Technology Network pathway, which again, in a sense, puts pumps and CGM at a common level to say that, well, if you've got a problem with hypos, actually, you've got a choice. You know, pump might be right for that person, but sensors at the same sort of cost might be a suitable thing. So I think things, hopefully for the individual who's sent that in, I think things are evolving.
Yeah.
I think the other thing to remember is that actually within the UK, I guess you're never more than 50 or 60 miles away from a centre that actually does offer CGM to those people within NICE guidance. And the difference is, you know, centres like ours and yours, we've been a bit ahead of the curve. We've spoken to our commissioners. We've said this is the idea, and we've got our local agreement, and other centres are kind of on that pathway.
Yeah.
But actually, I mean, I think all of us, at least our 4 centres, offer CGM in that according to NICE guidance. And so wherever you are, you're never, I guess, with more than 50 miles away from somewhere that can do that.
So if somebody has experienced recurrent severe hypos in the last year and they can't get CGM in their local hospital, what do they do?
I think they should look at, I mean, there's organisations like Input, which can help you work out where CGM is available. And if your local team doesn't offer it, then you need to, through NHS Constitution, you can get your care wherever you want to.
Be referred elsewhere.
Yeah.
On paper, and when we started out, I mean, I run an islet transplant service, which the indication is more than 2 severe hypos in the last 2 years, despite best medical therapy. And of course, best medical therapy is the use of CGM. And so we started out by getting a lot of patients being referred in for islet transplantation who actually managed perfectly well and were sorted out with a bit of CGM. So I'm sorry that your local hospital doesn't provide that, but have a look around, speak to Input Diabetes UK. They can point you in the direction of a local team that does offer that, and you're within your rights to go and find that service.
I mean, the bigger challenge is if you're not having problematic hypoglycemia, and you're in that scenario where, you know, and I think when we were talking about this earlier with the exercise, in fact, it was one of the questions we never got around to asking them, but one of the questions there is if you're doing something where it's actually really difficult to scan, you know, the Libre is not great in that scenario because you do need to be able to scan it. Whereas if you've got something that's transmitting, say, to a watch that you can just have a look at, and, you know, that does make a difference. So I think in some respects, the technology pathway that says actually, you know, a CGM might be better for you with multiple daily injections rather than going on to a pump.
Yeah.
And there's no cost differential, so actually choose one or the other.
Choose one or the other.
And I mean, NICE, with their recent surveillance review, sort of said, well, yes, we support that, didn't they? So,
and again, there may be, I mean, NICE have issued requests to stakeholders to talk about reviewing the guidance. So, and that process might take another 12 months, but again, that might move things further on a bit. So, I mean, that's a question more about access and stuff, I guess, slightly outside the remit of this, but hopefully that was helpful.
Yeah. So another question that we've had come in is, do insulin sensitivity factors vary depending on the blood glucose level? Does this make rules harder to use? I think my ISF also varies by time of day or night, but not sure if others experience this.
So that's quite a complex question, actually. And again, whenever we in a clinical consultation say, well, your carb ratio is this and your sensitivity factor is this and your basal rate is this, that number is always a complete compromise. Because actually at any given point in the day, I mean, if I've just run 5K, come back and had a glass of wine, at that moment in time, my insulin sensitivity and carb ratios actually are quite different. And the number we come up with is kind of a best guess compromise. Certainly, talking about taking the second part of that question first, talking about carb ratios through the day, there is certainly evidence and suggestions that for breakfast, your carb ratios, you need a bit more insulin per carb. I think through the day, physiologically speaking, there shouldn't be more than a 10 or 20% variation. And when you do get big differences, if you look deeply into the data, sometimes that's because maybe your basal rates are hugely variable if you're on a pump, or your activity levels are, someone is really active during the day and then not so at night. There may be some reason behind it, but it would be unusual for someone's carb ratio to be more than 30% out between lunch and dinner, I would say, and the same for sensitivity factor. Now, the other question was, does sensitivity factor differ when you go high? And one part of that question is, well, if you're really high and that's because you've got a little bit of ketones because maybe your pump was blocked or you've not got enough insulin, yes, you need far more insulin to bring you down once you cross 15 or 18. Some of that is because if you're rising rapidly, again, insulin takes so long to work that it feels like you need more. But within your kind of operating range of, call it 5 to 20, I don't think I've seen any evidence or data to suggest that systematically there's a difference.
I guess it depends why
you're
at
running
that
high.
level.
And
So if you're running high because you're ill, then of course your sensitivity
Yeah.
factor is different.
Yeah.
If you're running high because you've just counter-regulated from a hypo, of course your sensitivity
Yeah.
factor.
or your cannula's blocked. And
So
you've got
the short answer is yes, your sensitivity factors can change. And of course, as we said, all of the sensitivity factors that we try and calculate are a compromise, particularly because we mainly use sensitivity factors to judge correctional doses. The compromise that we make is always first don't overcorrect. So when I'm setting sensitivity factors, will tend to err on the side of setting quite high sensitivity factors, because the worst thing you can do with a correction is overcorrect.
Yeah.
And I always say it's always better, sorry, Peter, that if you are higher, if you're 15 or 17, I always want you to get down. I'd rather you get down to 10 with that correction, and then get to 7 with the second correction, then go 15, 2. And we always say more insulin doesn't get you down any quicker; it just takes you down lower. And that's something I use in clinical.
Well, and I think the point I would just endorse the point you made about the size of the bolus. So the bigger the bolus you're giving, the longer that takes to work, the longer its duration of action. So, as you say, if you're much higher, it may take much longer to get down. But I think the other factor that changes your carb ratio is obviously the amount of carbohydrate you take, and so there are European centres where you have a carbohydrate ratio up to 50 grams, and then when you go over 50 grams, you change that. I mean, I think frankly, as you say, it's a best approximation. I mean, people's carbohydrate counting, it's a bit like adding protein and fat into carbohydrate counting, isn't it? Actually, you've got to be really, really good and accurate with your carbohydrate counting for it to really matter if you add in.
And I think what this is coming back to is, of course, we set up our kind of what I call the structure, your basal rates, your carburation sensitivity, as a best compromise. And then when people are really working hard and trying really hard to get down, sometimes you can kind of get into this overanalyze. And certainly when you look at it from a longer lens, which we have the luxury of doing, as opposed to the person with diabetes sitting there with the data, you can sometimes see where things have been misappropriated, where you think, well, actually, that happened that one time, which sticks in your memory that I was high, took the insulin, didn't come down. So now you start thinking, well, I'm high, I need way more insulin to get me down. But that one high was because you were unwell, because it was a high-fat meal, because something else. Yeah.
And then the problem is, people often lose confidence in their bolus calculator settings, and so they don't use their bolus calculator. And we know that use of the bolus calculator probably gives you a 0.5% reduction in HbA1c. So it's really difficult, isn't it?
And it's one of those where the 30% times when things don't quite work are the ones that you remember, not the 70% time when it works.
The way I always describe it is to say all of the calculations we do are rules of thumb.
Yeah.
They're not rules,
Yeah.
realistically.
Yeah. And we've had quite a few comments coming in on the same issue.
Okay.
So, how many people with diabetes do you see using the Meow Meow? We are not talking about a cat here. We are talking about the device that attaches to the Libre, or similar transmitters to turn flash glucose monitoring into CGM. And somebody else saying, Meow Meow, yes or no? You've stunned him to silence.
Well, no, it's
a tricky one,
it's tricky.
isn't it?
It's really tricky,
difficult.
right? So I think we have to have a balanced discussion about this. I think there are definite benefits from streaming the data straight through, because you get the benefits that we talked about of alerts and alarms and seeing more data. But then there are downsides. Of course, the Meow Meow doesn't have a CE mark. It, technically for us, anyone who's using that needs to be aware that it doesn't have a C mark. We don't quite know what the algorithm is on the back end. You get a different number with the Meow Meow than you would through the Libre software. If there's a bug in your Meow Meow data, if there's an error in it, you don't really know who you can go to, and you can't go to Abbott and say, well, your sensor's wrong, this problem happened. So you've got to be aware of those caveats with it, and you've got to use it, understanding those aspects, I think. And if it works for you, it's good, but you need to maybe be slightly more. You asked, there was a question before about the accuracy of Libre, and we said, if it doesn't match, always test it, because even with the approved, tested, validated in 100 different ways algorithm, we know the Libre has errors. And now what we're doing is we're introducing another variable element, and you've got using it through Spike or F-strip, and again, the algorithms behind there, made by very clever people, and work, as far as we can tell, as well as the others, but it's just not had that stamp of approval. And so I think for us, if it's working for you, I think it's great.
I think I would echo that largely. I mean, we have quite a number of people using Meow Meow, often as a first step towards this idea of sort of looping from a personal perspective. I think that the challenges with using Meow Meow, it does take somebody who's thought quite carefully about their data to use them well, because a large part of the accuracy measure that we describe, this marge that we describe relating to sensors, doesn't relate to the sensor. It relates to the software that's interpreting the signal from the sensor. And realistically, what Meow Meow and devices like it do is they take the raw data from the sensor and have a different process of correction. So there, as far as I'm aware, there is no data that has been published by anybody that will tell you anything about the accuracy in the same way that we've seen with the manufacturer's data.
So we don't know what the MARD is of that data coming through, what the error margins are. So maybe the most sensible advice is if people are using that software for the benefits they give it, maybe there is a stronger responsibility to do finger prick testing to make sure that sensor is reading correctly, and that's for the user's safety as much as anything else.
And actually, of course, many of the people who do that will be using calibration.
And
tests.
and
of course, calibration itself is something that again changes the accuracy of sensors for better or for worse in some people.
A calibration at the wrong time can completely mess up the accuracy of the data.
Do you want to just quickly touch upon what sort of healthy calibration looks like?
So my rule of thumb, is that a natural tendency would be if you did a finger prick and it showed a number that was 3 out from your sensor, you'd calibrate with it. Now, actually, that messes up the system. And because if your sensor was under-reading, then it suddenly starts thinking, oh, I'm under-reading, and you might end up over-reading with an error the other side. So I've always said, as a rule of thumb, only calibrate when your finger prick is within 1 or 1.5 of your sensor reading. If your sensor is way out, trust your finger prick, keep an eye on it and see if it comes back. If it doesn't come back close, then that sensor really needs to go and you need to change it.
And any comments on arrows in calibration?
Yeah, and sorry, I should have said, of course, if you calibrate when you've got any arrow, it's likely to give you a false reading. And I don't know about different software, but there are different software have a different number of good calibrations you need to wipe out a bad calibration. So if you have calibrated when it's off range, then you're going to have inaccurate data. But eventually, if you get a period of stability, you want to get a couple of calibrations in to put the data forward. I think that might be different for different softwares. I don't quite know the final answer to that.
Yeah. And I think the other thing is making sure people wash their hands before they do that blood glucose for calibration. That's really common. Well, thank you very much. I think we'll finish up there. I hope you found this evening's webinar really informative. All the modules that you've seen tonight will be made available on the DTN website, and they are available to watch as either individual modules or as a webinar as a whole. If you're a healthcare professional starting people on the Libre, please let them know about the DTN modules to watch in their own time. And if you're a healthcare professional, then obviously tell your colleagues about them as well. I'd like to thank you for logging in, and we look forward to seeing you at our future Diabetes Technology Network events. Thank you.